There's several things I hope we can learn from each other while we're here in the sanctuary and during our meal together. And that is, you'll learn my story and I'll learn your stories, and that we'll practice them and we'll know how to tell others what our stories are. That's the most important thing we know we can do to influence what happens in the legislature and what happens with voters. So what I hope we can do is we can learn to do that a little bit. I can tell you what I know about what's going on in Oregon and the nation to get us closer to a better healthcare system. And then I'll offer some ideas for you. Where can you put your passion and energy to your best use? Are you a bookkeeper? Can you help Healthcare for All Oregon keep track of incoming funds and outgoing funds so that we have the fuel to do what we need to do? Do you like to speak? Do you like to table? Do you like to telephone call? Do you like to do basic research on where is money going right now for healthcare and where should it be going? So please think about your story, what the problem is right now, and what you can do to help. And in addition to all the other ways you can help, you can always donate money to help the Universal Healthcare Project. So I'd like to start with my story. I was a radiation oncologist for 35 years. I treated cancer patients, and it was an enjoyable career. I was usually able to help in the first few days just by relieving concern, by pointing out where the cancer was, where it wasn't, what we could do about it. You can't imagine what burden that relieves for people when they see where the problem is and what we can do about it. That was very satisfying. And then being able to use radiation to shrink these masses and relieve symptoms and, in most cases, help people live longer. That was all great. What wasn't so great was in the last 10 years, and I retired 12 years ago, I started seeing patients coming in with advanced cancers. Can anybody guess why?
They couldn't get the preventive care. They weren't seeing a doctor early on.
Right. They couldn't afford it. They couldn't afford the direct cost of seeing a doctor, or they didn't feel they could. They couldn't afford the health insurance that might have helped them get to the doctor. So they would wait. And you can imagine, maybe you've done this yourself or known family members sitting on the bed, edge of the bed at 3 in the morning with a chest pain. Or maybe you've had a weight loss and nausea that's gone on for weeks or months. And you worry about it. And you worry about your family. And those combined worries come together. Do I risk my family's income or even our house by making that visit to the emergency room or not? Some people wait out that evening and the chest pain turns out to be indigestion. Some people wait out that evening and are not there the next day. And that's happening all around us every day. People having to make a decision. Do I go in to the emergency room to find out what this is, or do I wait? So some people wait weeks, months, years even, and then we would see them come through the emergency room with a crisis. It could be blood, coughing up blood. It could be severe pain that they couldn't handle anymore, and they'd come to the ER. And I got acquainted with the ER docs that way. Then, of course, we'd have the diagnosis, and we would pour thousands or hundreds of thousands of dollars in to try to help that person. And you can guess we were often behind the 8 ball. It was like being socked in the gut every time that happened. So I started realizing other countries don't let that happen. They don't let that happen. So that's my story. You may have your own personal story, or you may know somebody in your family or in your community or even through the news where something like this has happened. There's something we can do about this. This is sort of a unique thing, a wealthy country that does this to its own people. So I want to graphically illustrate this with a few stories. You'll show on video. The first is about a man in his mid-50s who was an artist in Taft, and you can go meet him. His name is Tracy McEwen. So if you stop in at the painting gallery across the street from the glass blowing place, you might meet him. So he'll tell his story. And then we'll have an interview from a young woman from one of the countries that has universal health care that we would not expect would have universal health care. And then finally, a very short cartoon about the ideal that we're seeking. And then we can go into more about how the UCC has been involved in seeking universal health care for at least 30 years, so that we're just in part of that process. We can show you the resolutions that several churches have signed, and then our UCC conference passed last September, where Adam and I met the man who does the sound, where that was passed as a conference resolution for urging our legislator to pass universal health care system for Oregon. So one of the things I would like to offer for your congregation is to create your own resolution, which you can model after the conference one if you wish, or one that we use for the Congregational Church in Corvallis. This is one of the many things that you can do. So any questions before I show you some of these sort of testimonials?
Is the state actively looking at this?
Yes.
And where are they in the process?
The question is the state actively looking at universal health care? And yes. It has activists like Healthcare for All Oregon has introduced legislation every session for the last 4 sessions. Not expecting that it would get out of committee, but exposing the legislators and the media and the public to the concept. And at the same time, letting Legislative Review Office look this bill over and say, that's inconsistent with the Constitution, or here's what has to be changed if you want this. So it's putting it through the fire of examination rather than when we get sometimes ballot measures come off the desk of somebody's, iPad, and they're not really tested. Well, this legislation has been through legislative hearings and the Legislative Review Office, and so we are still planning to present it to the public as a ballot measure in 2020. We have to be sure that we've met certain benchmarks before we do that, but that's still the plan. And we will introduce it again to the legislature. Will the legislature act on it? I have doubts, but they did have what they called a Universal Health Care Legislative Work Group that has been meeting every month since February. And their charge from Representative Greenlake in Portland was to define the principles and the methods that we might use to get universal health care for our state. Excellent people on the board, maybe 20, but they didn't really define universal health care. They got distracted into certain other issues, like, do we do a Medicaid buy-in? That'll get a few percent in. And do we do a Medicare buy-in? That'll get a few percent. It kind of strayed, but we don't give up. We keep after them. So that's on the state level. On the national level, there's Bernie Sanders' Medicare for All bill in the Senate, S 1804. We will strongly support that. And there's one in the House called HR 676 that Representative Blumenauer, after years of arm's length about anything related to single payer, after Bernie came through with such a response to single payer, I think he said, okay, my constituents are not going to punish me for speaking out. And he signed on to the House version, the first one, in January 2017, and then DeFazio, and then Susan Bonamici. So we have 3 of our 5 representatives signed on to the national version of single payer, and we have 1 of our 2 senators. Anybody guess which one?
Just one thing. I saw a recording. It was on Facebook, and somebody asked why the question, yes or no. These guys can get on a dance, obviously, and say everything but just yes or no. And then she said, you didn't answer my question. And they go on and on out there for the whole idea. Well, why aren't you sponsoring the bill? So.
Anybody have an answer for him? It's Bill, isn't it? Yeah.
I think that's an oracle question. I think I know the answer to that. He's owned by the health insurance company.
So if you look at his campaign contributors, one of the close to the top is insurance companies.
He also helped marshal through, which was bad, that Obama wanted, was fast track on the TPP.
Yeah.
I mean, Republicans punked Obama for 8 years, and then when it came time for his TPP fast track, well, they were right on board. White was right there along with Kumbaya.
So we're getting into politics inside one of these buildings, but all I could tell you is please be fully aware of how your senators and representatives are thinking. Is Kurt Schrader in this district? He needs to be brought on board. And so regardless of party, in fact, I don't think you could say which party he's in, just write him, tell him, please, why aren't you one of the group, the representatives signing on to the House bill?
Or just say, with your Blue Dog friends, why aren't you engaging them and getting them to come on board, with bipartisan effort?
Yep, yeah. So Representative Schrader is certainly a reasonable person to influence, kindly at first, and then bird-dogging if you have to, which is kind of what they did with Senator Wyden, I think, pinning him down. And then, of course, if you know anybody in east of the Cascades, pressure Walden or maybe his successor. I have postcards, if you would like, that already have Wyden's name on it, and you can just fill them in. Tell your story and tell him to get on board. Did I get close to the answer?
Yes, you mentioned something. How do you define universal?
So universal means everybody's in from birth to death, regardless of residency status. There would be probably some qualifications, like being a resident for at least a certain period of time. We as a state have to decide, how are we going to protect ourselves from the possibility of people coming in when they haven't really paid into it. But we can decide those things. But to spend the effort of figuring out whether you're eligible or not takes more money than providing the care. So that would be the first thing. Everybody's in, birth to death. How is it paid for? Well, all the money that's now being filtered through dozens of insurance companies and dozens of plans would be funneled through a central fund, and we can decide how that should be managed. It could be a state agency. It could be something like SAFE, the workman's compensation thing, which is quasi-public. We can pick an agency that we trust to manage this fund of money, and then when the family practice doctor sees you, he or she fills out a form, sends it into the agency, and gets paid within 2 weeks or something on that order. So that's the ideal. Whether it covers vision, dental, long-term care is up to the population. How much are we willing to pay in taxes to make that happen? But one thing I think you can reassure everybody is that for the amount that we're now spending through our insurance premiums, out-of-pocket, deductibles, co-pays, for all of that, if we paid the equivalent amount of taxes, we would get a much better system simply because of administrative efficiency.
Are physicians on board?
Are physicians on board? I would say certain ones. Primary care is a little more likely to be on board. Psychiatry is more likely to be on board because they are in the trenches seeing what happens to people's lives. If you're a specialist working for Samaritan in Corvallis, you may be protected from the headaches of dealing with 50 insurance companies and all of the plans, and you may not feel it. But I'd say probably 50%. You may have seen the recent poll of young people aged 18 to 34. It's about 70%. But we do need to get doctors more aware.
Would you expect the pharmaceutical industry to fight this?
Oh, tooth and nail. Pharmaceutical industry will fight this tooth and nail. They are doing what they're doing because we are allowing them to do it. And you can't blame them if they're allowed to do it. It's free enterprise. You got to make a profit. And who's to say how much profit is right or wrong if you're just thinking in purely business terms? If you're thinking of a way of keeping the population healthy, then we have a right to be very mad, very upset, and do the right thing, even if it's to the point of nonviolent protest. Whatever it takes, we've got to do something. And the state does have legislation pending to negotiate prices down, even for our state. But we really need it on a national level, and there are bills for that also.
Medicare doesn't have the right to negotiate prices.
No. Anybody hear the name Billy Towson ever? He was a lobbyist for the pharmaceutical industry when 2003, when that Part D was passed, and he was as good a politician as LBJ, but in the opposite camp. He forced that through. Medicare can't negotiate price. They can keep whatever price they want. Once he gets that done, he goes to work for the drug industry at a much higher salary than what he was as a representative. So it's enough to make you mad.
Are you one of the mad as hell doctors?
Yes.
I thought that was a good segue.
Right. Yeah. So you might notice this car out here. It says "Mad as Hell Doctors," and the story about that was Adam Klugman, who lives in West Lynn, whose father was Jack Klugman from Quincy and The Odd Couple, and he's a liberal media agency person. He saw that in 2009 they were not even going to allow anybody to testify in favor of single payer. And this was in Senator Baucus's finance committee. They were mad. And Gary Jelinek, who was the Kucinich's campaign coordinator, they were friends. They said, we're both mad. And Adam Klugman's favorite movie was The Network, where the people went to the windows and shouted, I'm mad as hell, I'm not going to take it anymore. So he had this idea, and he wondered if any doctors were that mad. And he asked around here, and they said, well, call Paul Hochfeld down in Corvallis, ER doc. Paul said, yeah, this is not good. He called me, and we talked about it. We said, were we mad enough to invest $15,000 in a Mad as Hell Doctors sort of tour? And we didn't think we were. And then the next day, one of us called the other. Yeah, I think we're that mad. So we went across the country for 3 weeks, Carol, was it? Stopping at 40 places. And we had meetings like this, some larger, some smaller. And we went across the country and landed in Senator Wyden's office, and he politely listened to us and ignored us. And pretty much the same way with Representative DeFazio. But yeah, we're still mad. Well, I want to give you a graphic story, and you can use this one if you don't have others.
I'm allowing healthcare authorities to use this information, and my name is Tracy McEwen. This is one of my pages. So before my stroke, I really loved painting. So I had, unfortunately, I had a stroke. I felt great. I walked, I exercised, I did everything. I was never a smoker. I was a picture of health. I was in intensive care and like pretty much out of it for like 27 days.
Wow.
So the bills mounted up I was life flighted from here to OHSU, and it was several months after the fact that I heard how much it was, and I think it was like $40,000, which of course I was floored by. So that dovetailed into a huge amount, and so there's no way in hell I could pay for that. So I was a beneficiary of Oregon Health Plan and Medicare, and my sister and my friends, but it made a really big difference in my life because I'm so leery of prices, and the fact that I wanted to make like artwork. I used every ounce of money that I had, so it would have been really nice to have a doctor say, "Let me check your blood pressure." What the hell? Yes, you're too high. So I didn't realize how close I was to like stepping off the edge. And so after I remembered a gentleman from the Netherlands, and I have to say, he looked at me and said, "I don't get it. Why are Americans doing..." The case in point is everybody should have health care. Everybody should be cared for from the beginning, and so it shouldn't be a big thing.
So just a little more on Tracy. He was the artist I talked about a while ago. I had met him about 3 months before this stroke, and he spoke very smoothly, like you and I. And he was a little worried that he didn't have health care, but what bothered me most was that he wasn't mad about it. He had put himself in a category of one of those that, for some reason, doesn't deserve health care. Then I got a call from his friend, the artist across the street, Kelly, who's a glassblower, and you can meet her if you go out to Taft, that he'd had a stroke. He, in fact, was on his way home from the exercise facility. And as you heard, he didn't smoke, and he kept his weight down. But he made too much money to qualify for Medicaid and not enough money to buy health insurance. So he was stuck there and didn't know that his blood pressure was 240 over 150. Had he known, a 38-cent pill a day would have protected him from this stroke. So you saw the $40,000 figure there. That was just the first 2 months. Of course, he qualified for Medicaid then. That's why he said he was so grateful for Medicaid and then Medicare. He was disabled. Then that was another $400,000 of our money to rehabilitate him to the point where he can paint again and speak again. Any questions? You're free to use that story, and you can find it on our website. Go to Healthcare for All Oregon if you want to see it again, and look under stories. And I'll show you how to use the website too, although I may need to find out what the Wi-Fi code is. So any questions about his situation or others that you're aware of? It's like that?
This had to have been 12 years ago. And it was about a young man who was on the Oregon Health Plan, and he just needed a salve for his skin. He had a skin condition. Somehow he got to the point where he didn't qualify anymore, like this just didn't have, made too much or something. At any rate, they wouldn't provide it for him, so he couldn't put it on. And then he ends up getting this horrendous skin infection, ends up in intensive care, same story, tons of money. And if he could have just been provided with this salve, which was too expensive for him, but would have been a drop in the bucket compared, and just the suffering he went through.
Yeah. So preventive care is logically something that saves money. If you're just looking at dollars and cents, you might come to a different conclusion. We might want to encourage people to keep smoking. Why? They die earlier, and they're less of a burden on our Social Security system. Right? So if you look purely at preventive care as a way to save money, that necessarily isn't the best argument. But quality of life and saving individuals money, I think that's a very strong argument. So the next story is from a young woman from Brazil. And I was at the Fall Festival in Corvallis last month, and just handing out invitations to a movie that we were going to have. And this young woman came by, and I handed her the slip, and I could hear this accent. And I always ask people with an accent, "You sound like you're from a country with a better healthcare system than ours." And of course, it's pretty safe.
Yes, yeah.
So she said she was from Brazil. And so here's her story. Now, Brazil is not a wealthy country. It's not even in the 34 nations considered qualified to join the Organization for Economic Cooperation and Development, like most European countries are. But here's what Brazil has done for their people. Okay, you're on.
Okay, I give to Healthcare Oregon permission, I'm sorry, to tell my story. Yeah, so I'm coming here to the Fall Festival in Oregon, and I was telling that in Brazil, my dad had a liver transplant about 10 years ago, and it was all for free, and all worked well, and he had all the transplants. He didn't have to pay for anything. After that, to be in a hospital and for all the medications that he had to take after that. And he also had a pancreatitis after the transplant, and that was all covered by the public health care and all the medications. So he's doing well now, and he's more than 10 years ago, and he's working. He got back to work like 1 year after the transplant, and now he's only taking the rejection medications, and it's everything covered by the public health care. So we are very, very happy. We are blessed, actually.
But aren't your taxes unaffordable to pay for all of that?
We have a lot of corruption in Brazil, so I think they would have money if they would not steal so much. But some things very work well, like when they have to save money, they don't cut money from health or education. So they cut money for many important things like safety and science, but they don't cut money from health and education. And of course, it doesn't work well in all the country, but where I live in South, and it worked so well. Like my dad had insurance, but for the transplant he had to give up because the insurance would not cover. So from the day of the transplant forward, he gave up of the insurance and he never could use it again. So everything from that is all covered by the public health care.
Wow. Thank you.
Yeah, you're welcome. It was a pleasure.
So this young lady, this young lady, I think gives an accurate picture of Brazil. There's a couple of words she might have been hard. She said her father also had pancreatitis, which can be a very, in this country, very costly thing to take care of, and they took care of that also. She also said it isn't uniform throughout the country, so she's from the south, down near Sao Paulo and Rio, and I imagine if you get up into the north in the jungles, just like if you get in some parts of our state, it's hard to guarantee the kind of care that her father had. But I think this is a good thing to keep in mind, is that even a poorer country with the right motives and thinking can make sure they get the health care and education. So we're the wealthiest country. Maybe we can do it too. Any questions about that?
What is the best model of another country's health care?
So the best model of another country, for a long time it was France, and I think probably still is. They have, and just like Taiwan, they have a single funnel of money. They have the cards where you carry your entire medical history on it, so that when you go in and they take your card, they have your records wherever you're traveling in France or in Taiwan. In Taiwan, for example, because of that single risk pool and everybody's in it, it's very easy to track fraud or overuse. Like somebody who's using too many drugs stops at one drugstore and goes to the next one in the afternoon. Well, their system picks that up. Also, you may be aware that the pricing and the frequency of various numbers of medical services varies widely, even within the state, but across the country. So if you have a single database and you're looking at it and you see this spike in appendectomies in Corvallis, Oregon, why are they doing so many? And you narrow in on that little town and you find that it's one physician out of 10, one surgeon. Why is he or she doing so many? And you narrow in and you find out there's a good reason, maybe. For some reason, that doctor had all kinds of people with pre-existing illnesses that led to this. But most likely, you'll find out that person was doing too many procedures. And so, I forgot how I got onto that, but the best country. France, Taiwan, Japan, a capitalistic country. They have private practitioners. Their people are as old as we are. They have more technology than we do, but they cost half what we do. So any argument that says, well, the U.S. has so many old people, or we have all this technology, that's why our system costs so much, that isn't true.
I don't know if you're going to have it in your presentation, but why it's so important that everyone's covered as far as like where we are with Medicare. We have a concentration of people that, because of age, are going to have more services, and then younger people in our present system who decide not just to opt out because, oh, I'm healthy and I'm young and I'm never going to die.
Right.
You kind of know where I'm going with that?
Right.
Why we need a broad section that amortizes it out and
you
spread how the risk.
Well, I think you've given us a good start. Can you embellish a little bit on why that's important?
Well, statistics say that if you have everyone covered, then you're going to have these younger people at the one end. Their healthcare costs are going to be smaller, and then at end of life, just statistically, you're going to have people that they're at the point in life that they're probably going to need more health procedures, maybe knee replacements or hip replacements, or just you live long enough, you might get that cancer that you've avoided all these other years. Maybe skin cancer because you did too much sun when they didn't have sunscreen. And so it spreads the costs out, and since everyone's paying in and the risks are being spread out, then it actually brings the costs down. Where in our present system, it's skewed towards a lot of people not in the ones that are covered when they cross the Medicare line. Then they're older and are using the healthcare system more often, and maybe because they didn't get it in earlier years, the birds are coming home, or what's that saying, on things they neglected, and now they're having extreme costs, maybe intensive care and other things they might not have if we had a universal healthcare system where they were getting good care, preventative care from womb to tomb.
Thank you. You did that better than I could have. Thank you. So you have to think about how you're going to pay for that. And right now, we're asking young people to pay premiums for insurance policy the same as you and I would. And their income level in general is lower. Age group 18-35 is lower than people in retirement. So we're asking them to pay this same amount that wealthier people do for private insurance. Is that fair? What if it's a tax-based system where the young person isn't earning much yet, and they get taxed on a percentage of their income, and the retirement person gets taxed on their percentage of income?
Is there any synergy between the forces that are looking for universal health care and other groups that may be looking to reduce our massive military industrial spending as a way of funding universal health care?
I hear that as a rationale, and I agree with it. And I don't know enough to say that we're spending too much. I think we are, on defense. And maybe Jobs of Justice is probably better at linking other societal expenses, unnecessary expenses, with how we could use that money better. But it's a good point. Yeah, I think you're right. Oh, she has a...
Pardon me. My cousins in Denmark have spoken to me about their what they call socialized medicine, and their tax rate is very high, but they're totally taken care of, cradle to grave. They're supposedly the happiest people on earth. They have almost no poverty. They have almost no homelessness because their high taxes cover more than just their health insurance. There's all kinds of social benefits that they get for their tax money.
Yeah.
One of our issues, I think, is the size of our country in terms of implementing something. One of the things that I saw when I was in hospice is that I was negotiating hospice benefits from a lot of different insurers to cover the cost of care. It seems like with increased technology, doctors are using that technology sometimes beyond the point that it is reasonable, and it's increasing costs. And I don't know how you get folks or physicians, nurse practitioners, to maybe watch that a little better.
There is an article this month in the Annals of Internal Medicine addressing your very question. Even before we get to a universal healthcare system, can't we shift the emphasis away from let's do CTs, MRIs to figure out the answer to this, rather than listening and letting the patient's history help you figure out what that is? And in hospice is strong in Oregon, as you know, and the presence of hospice helps reduce that tendency. People are more brought earlier into the conversation of deciding, do I want to go through all these tests and all these chemotherapy treatments? How do I want to spend my life? And that helps reduce that cost.
What's interesting is that statistically, folks are being referred later and later to hospice, in that most expensive care is the very last few weeks.
Yep. Yeah. So we do need better education, but but Oregon is ahead of most states with its advanced directive planning and its physicians ordered life-sustaining POLST, and everybody in the room should have one, and put it on the refrigerator. And if you do not want resuscitation when that EMT comes in, they are obligated to. That's where they look first, is on the refrigerator, and these are pink, so they catch their attention. It doesn't guarantee that they'll honor it. If there's any doubt at all, they're going to resuscitate, and that may be the way you would like it, but at least that's one step that Oregon has taken to help honor people's real wishes.
If we had universal health care in Oregon, would doctors be obligated to accept it?
Would doctors be obligated to be part of the program? Whatever we design has to have the proper incentives to keep doctors involved, and that means giving them a negotiating power. That's the way you do in Canada. They sit around a table and So somehow we have to allow that. What's going to allow this doctor to stay interested? The system we have now is burning physicians out rapidly because of all the private insurances, the denials, being on the phone, waiting for pre-authorization. It's very frustrating. And so my suspicion is that, well, I know for sure that Canadian primary care doctors are very happy. They're actually paid more than in this country. And it's because they don't have to deal with this sitting across from somebody and saying, this is the treatment you should have, but you don't have the right insurance.
Lots of doctors don't like to accept Medicare. And I just would hope that something like a universal system would not allow physicians to opt out. Otherwise, people won't be cared for.
Right. I agree. It should be mandatory in participation, and it should be a system that allows the doctors to negotiate. In some countries, the doctors are very upset, and they go on strike and so on. And that's their negotiating power, like in Germany.
They get paid less for Medicare patients?
Yeah, that's the main complaint. But my friend Bruce Thompson, who is a primary care doctor, family practice doctor, said that the Medicare was less of a headache for him than primary or private insurance companies because he did not have all the pre-authorizations and denials. He got paid less, but it was quicker and it was more reliable.
You briefly touched on the edge of Oregon is ahead of other states, and I'm curious what other states are moving in this direction or looking at it, or who's out there with Oregon?
Right. Anybody? Yes? California. There was this... Colorado. Washington. Vermont passed the first steps of a single-payer system in 2010. They did not put in the bill how to fund it, and predictably, when it came down to that kind of a fight, it lost ground. But they're still working on it. New York is, Massachusetts.
How do we handle? We live in a very litigious society. A big expense for doctors is malpractice insurance. How can we handle that?
So the question is about malpractice insurance, and the very best prevention of malpractice, at least malpractice accusations, that I can think of is a system where you're covered from birth to death. When I saw a patient and they had an adverse reaction, like a bowel stricture from the radiation, and it might have shown up 5 years later. I may have done the wrong dose or may not have, but that patient's wondering, how am I going to pay for that surgery and the recovery? And they may have liked that old Huntington guy, but he may have made a mistake. I'm going to go after him. And but if you don't have to worry about the costs of complicated care or even malpractice, you're less likely to need to sue. If my bedside manner is terrible, I deserve to be sued. Or if I just make gross negligent decisions.
Just a caveat on that, I'm going to see about getting the video so we can all see it. But it's been really a canard, this whole thing, with a fraudulent lawsuit chasing, ambulances, and it's called hot coffee. And everyone heard the thing about the woman who spilled hot coffee from McDonald's. And everyone was joking about it. It was a scene on Seinfeld where they made a big joke about it. It was even on the news, joking about it too. This woman had severe burns. She had to have plastic surgery, on down the line. But literally because of the ignorance of the populace, and everyone was like Velcro on that story, they believed it and went to the bank. And so they actually had passed tort reform, which is basically that you can't get only so much money. And it passed in Texas. And George W. Bush was very much on top of that, and they all bought into it. And they had one case in point where a family did sue. There were twins. The one boy didn't get enough oxygen, permanently disabled. They actually went to court, got a judgment because of tort reform, even though the jury awarded a huge amount because of the new law, so supposedly to lower insurance rates to protect the doctors. They had no care, so guess who's going to pay for that young man? And what happens when his parents die? And what about his lost life? The taxpayers. So it was just the people bought into it out of their own ignorance, and because it was a lie. You got to see that video. And there was a whole lot more, and I don't want to take the time, but I'll see if I can get it. You maybe check it out at the library, the complete hot coffee. It's a wake-up call.
I agree with you. Putting caps on reimbursement for malpractice in Texas has not reduced overall medical costs. It may have reduced their doctors' malpractice premiums a little bit, but that's not the way to control malpractice. Well, we're getting within 5 minutes. I want to show you a simple solution.
Imagine a future with no healthcare bills, no confusing plans or restrictive networks. It'll be simple. One quality plan for our whole lives. We'll be free to have the job we want, not just the job that provides insurance. We'll be free to see our own doctors and receive the best care for our families when we need it, not just when we can afford it. We won't have to put off seeing the doctor and risk getting sicker. We'll be free to have the care our doctors advise without worrying how we're going to pay. Freedom from financial worry. Freedom to be healthy. Join thousands of Oregon physicians and patients who are working to make it happen. Help us. We can make this real right here in Oregon. Now.
So Adam, if you or on the group can decide whether we should break for food and we can talk a little more about specific things that you can do to help us get a better system, it's up to you.
Yeah, why don't we, why don't before, like one of my questions is, what do we do now? What can we do? And why don't we discuss that before we go to dinner?
Okay.
Does that make sense? Yeah, let's do that. And then at dinner we can tell stories. And
can you get us on your Wi-Fi? Okay, I'll leave the... Maybe it's already on. Oh, it's on Xfinity. So I guess what you can do now is what you're willing to do. One thing you can do is to create a resolution like the conference did. So I'll just pass these around. We have the congregational church in there now, but you can, if you like the idea, you can just alter the wording a little bit and substitute what you would prefer.
Are other denominations involved?
Other denominations? Oh, yes. Other denominations are the Western Diocese of the Episcopal Church and the ELCA Lutheran Synod. So, yeah.
Has there been any agreement with ecumenical ministries?
Yes. Ecumenical Ministries of Oregon, after many years of being very cautious, joined Healthcare for All Oregon. They don't have a resolution that I know of like this, but they're part of Healthcare for All Oregon.
I meant to ask before. Everybody here already knows, in February I had an event. I chose not to go for reconstruction because I couldn't afford the copays. I couldn't even afford what was already done. Will universal health care still have copays?
That's up to us. The most active people in this are saying no copays, but if you look around the world, almost all of the countries that have good single-payer systems do have small disincentives for overusing the system. I want to introduce Gary Sinnen, also from the Clackamas Healthcare for All Oregon chapter, and maybe you could.
Good evening. It's nice to be here and to be with Mike and sharing this with you. I do want to let you know that we've had a very active chapter of Healthcare for All Oregon in Clackamas now. We're finishing up our second year. We've been tabling at community events like Oregon City First City Celebration, Gladstone Community Festival, and others, trying to build a base of support for the ultimate ballot measure fight. And I do have information about where and when we meet that I'll share with everybody. Basically, third Wednesday of each month at the Providence Willamette Falls Community Center. I have this written down, and I can share that with you at 6:30. And we welcome anybody who wants to come and be a part of our group. No strings attached. You can come and see what we do, get involved at whatever level that you want and can. Organizationally, we're definitely looking for expertise and help with our advocacy efforts in many sectors, as Mike was mentioning. And I do have with me, thanks to Pastor Adam and his office help, faith statements of support for anybody to sign, so we can enter you in our support base and start to build a connection with you. So I'll pass those out right now, if that's all right.
And let's see, are we online, Adam? Okay, so if you want to go online to learn more about Healthcare for All Oregon, just type in hcao.org, and you'll see this. And there's an opportunity to share your healthcare story like we started out with, becoming a member, donating, volunteering. And then if you want to know specific things that you could do, go over here to those 4 bars, and then here you can learn about what the problem is, how we define the problem, what the single-payer solution would consist of. There's movies like I just showed you, in this setting, stories that we have collected, letters to the editor, and so on. And then my particular area that I spend a lot of time in is in speaking about this. So you click on that, and it goes into how to prepare a talk and present ideas, what kinds of, there's slideshows that you can pick slides from. 3 questions, 9 answers about healthcare that are sort of the basic questions and the answers to them. So there's a lot of resources here. It's kind of like walking into a library on universal healthcare. So I encourage you to use that and to connect with Gary. Oh, if you're not online, so Gary, maybe you can give a contact. Right. What? Oh, if they're not online? Yeah, probably if they don't have Wi-Fi, or they might not want to go to the library for that. I guess call a UCC church. Yeah.
Could they even, like, just off the top of my head, maybe send a self-addressed envelope or just an envelope and mail it to your, whatever address they could mail it to, requesting the various things you've been passing out today?
So we want to be able to hand out some literature. We'll be doing canvassing, by the way, more and more, going door to door, letting people know that there's a problem if they don't know it already, and encourage them to take part. And then we can leave contact information in that literature.
Hi everyone, this is Adam Erickson, reminding you that no matter who you are or where you are on life's journey, you are welcome at Clackamas United Church of Christ. We are located at 15303 Southeast Webster Road in Milwaukee, Oregon. Our worship service starts at 10:30 on Sundays, except for during the summer months we start at 10 o'clock. If you'd like more information on our church, you can visit our Facebook page or our website at c-ucc.org. You can also reach out to me through email at adam@c-ucc.org. Until next time, grace and peace be with you.